Well, we are back for another Connect to Healthy Living event, and I want to thank all of you for coming and attending live and or virtually. And also want to commend you for just taking an interest in your own health and learning more and really being your own advocate in this arena. I myself am looking forward to tonight's presentation. We have two excellent presenters, and I know that you will leave with minimum 3 things of new information for yourselves. So our first speaker is my readers, Dr. Fukuda, and she is with us. She is a neurologist. She received her medical degree from Rush University. Then she went out to Pittsburgh, University of Pittsburgh Medical Center for her residency. And then she decided to come back out west, or I should say come out west, to UCLA for her fellowship in vascular neurology, and her second fellowship she's currently almost finished with, and it's in interventional radiology. So I think she's going to have definitely a lot of great information to share with us. Our second speaker is Angie West, who is the face, the brand for the Comprehensive Stroke Center at Long Beach Memorial. Angie has been with the hospital for about 20 years. Yeah, and always involved in the program. She led the team to get certified as a comprehensive stroke center by the Joint Commission, and which is not an easy task whatsoever. So she also does many education events in the area. So without further ado, get comfortable, and just absorb all this great information you're going to hear tonight. Thank you. And I'm sorry, really quick. There are going to be some, rightfully so, you're going to have some questions. We ask that you wait till the end of the presentation, and then we'll have an open session for questions, and happy to answer them. And for those who are online, be sure to write your questions in the chat area, and then we'll read them, and so that they're included for some responses. So again, thank you.
Thank you. Hello, everyone. Thank you so much for being here and attending this lovely event, and thank you again to everyone who made this event possible. As mentioned, my name is Keiko Fukuda. I am a neurologist by training, and completed most recently my vascular neurology or stroke neurology training at UCLA. And currently completing my interventional neuroradiology training at UCLA, and part of UCLA actually spends time at Long Beach Memorial as well, and we provide stroke care. We've been there since, I believe, 2011, so well over a decade now. And later on in the talk, I'll go over exactly how these two fields overlap. And this is just a picture of our group here at UCLA. On the left, we have Satoshi Tatashima. He is a trained neurosurgeon from Japan, but has been in the US for many, many years now and completed additional training at UCLA. Here we have Reza Jahan. He is a radiologist by training, and was part of the instrumental group at UCLA in running numerous clinical trials related to endovascular treatment for stroke, as well as Gary Duckweiler here. He is also a radiologist by training, and one of, I'd say, kind of the grandfathers of interventional neuroradiology. Has been very, very prominent in the field in terms of developing things like aneurysm treatment, which we unfortunately won't go into a lot of detail about today. We also have 2 neurologists on staff, Maynor in the red. She is a vascular neurologist like myself, and Victor Zader is a neurocritical care specialist. But all of us actually spend majority of our time treating stroke patients through interventional radiology means. And we have 3 fellows as well. This is Catherine Peterson, Charles Beeman, and myself. And then really we couldn't survive without all of the amazing women in the front as well. They make our whole group possible. So if you ever do encounter us at Long Beach, just know that it really takes a village in order to make everything work. So without further ado, this whole event is actually very appropriately timed, as May is National Stroke Awareness Month, as sponsored by the American Heart Association, which is the larger organization of the American Stroke Association. And I'm not a representative of the American Heart Association, but this is their motto is Together to End Stroke. So I'm really happy to be here and talking to you about stroke. And just as a little bit of an aside, I've been involved in stroke and stroke care and stroke research since 2009, and that was actually how I decided to go to medical school and really pursue this career. So the topic of stroke is really near and dear to my heart. So I've been doing this now for almost 15 years. So, talking about stroke really actually begins before one enters the hospital in this pre-hospital setting, or generally in someone's home. Here, when someone develops symptoms of a stroke, the best advice we can give you is to call 911. 911 will dispatch paramedics to wherever the stroke is called for. And if you're fortunate to be living in Los Angeles County, which I assume you all are, we also have something called a mobile stroke unit, as shown here, which comes equipped with a neurologist, a CT scanner, a nurse, a technician, and a paramedic on board. And if there are signs and symptoms of a stroke that get dispatched through 911, the mobile stroke unit will actually tag along with those paramedics through the county, and after a discussion with the paramedics on site, they will oftentimes decide to basically allow the patient to come into the mobile stroke unit and get a CT scan and a very fast evaluation by a neurologist. So that we'll see later on that stroke, time is brain, and acute stroke is really comes down to getting treatment as fast as possible to have the best possible outcomes. So just to go over stroke by the numbers, in the US, actually, every 40 seconds, someone has a stroke. It is currently the number 5 cause of death in the US, which is actually an improvement over, I'd say, the last 10 plus years. I think it was the 3rd or 4th most common cause of death, so we're actually improving in terms of our numbers. That being said, though, 1 in 4 strokes are in people who've had a previous stroke. So in those who've had a stroke, unfortunately, the risk of a second or even third stroke becomes significantly higher. And there's also a number of disparities that exist within the incidence of stroke. As 55,000 more women every year tend to have strokes compared to men. Despite these numbers, stroke, unfortunately, is still the number 1 cause of long-term disability in the US. And knowing all that, actually, 80% of stroke is preventable, so that's why we're here today, to try and talk about how we can prevent stroke from happening in people like yourselves. Speaking a little bit about disparities again as well, more women actually die each year from stroke than due to breast cancer, and unsure if that's related to improvements in terms of cancer care for breast cancer or delayed benefits we've seen with stroke care, but our aim is to really improve these metrics and improve the mortality rate related to stroke for both men and women, but especially for women. This is actually, I think, a very interesting picture that just shows the overall mortality rate of stroke across the US. And living here in California, we're actually doing much better compared to other parts of the country. The parts here in the southeastern area of the US is what we call the stroke belt, so to speak. And that's why being very interested in stroke care. I did do my residency. I'm originally from California, but I trained out in the East Coast as part of the stroke belt here in Pittsburgh, Pennsylvania, and worked at a stroke center where we saw about 3,000 strokes every year. So looking at California, though, in a little bit more detail, the data looks a little bit more promising compared to the rest of the country. This is the overall prevalence of stroke among adults over 18, and this circled in green is actually Los Angeles County. And overall, doing fairly well. This is at 2.9% of the overall population end up having strokes, which is better compared to many parts of Northern California as well as Central California. And this I actually view as a very promising number as well. This is the stroke hospitalization rate for every 1,000 Medicare beneficiaries. This is around 10 out of every 1,000 Medicare beneficiaries get hospitalized for their strokes. So that means that the patients that are having strokes are actually arriving at the hospital and getting treatment for their strokes, which is really the most important thing that you have to do if a stroke occurs, is get yourself to the hospital as quickly as possible. So, and that is really represented by as well the stroke death rate here being one of the lowest in California per 100,000. So stepping back a little bit, first I want to just clarify what the word stroke means, since I think a lot of people have different understandings of what it is when we say the word stroke. Stroke really just means injury and damage to the brain, to the healthy brain tissue. And when we define it as such, there are actually two major buckets or causes of stroke. The first on the left being ischemic, which is related to actually a blockage of the healthy blood vessel, leading to damage to the brain tissue here, versus hemorrhagic stroke, which is related to damage of the blood vessel and leaking of blood out of the blood vessel, or so-called hemorrhage. And today we're going to be focusing on ischemic stroke, as that is the much more common type of stroke at 87%. Hemorrhagic strokes are around 13% of all strokes that occur. Still a very important type of stroke that unfortunately we won't have a lot of time to talk about today, but it is something to note as overall the incidence of stroke in patients over 65 has declined, so that means we're doing a much better job at improving things like risk factors, which Angie will go over, and reducing incidence in that way. But unfortunately, the incidence of stroke in younger populations is on the rise. And I do think over time we will see that this number of hemorrhagic strokes will actually be rising as more younger patients are having strokes, and more of our older population is doing a better job at preventing ischemic stroke. So these numbers will likely change within my lifetime. Again, going back to women and stroke, unfortunately is actually the third leading cause of death for women compared to the fifth leading cause of death for men. And as mentioned previously, 55,000 more women tend to have strokes every year compared to men. And because women in general tend to live longer than their male counterparts, unfortunately, stroke will have more of a negative impact on their lives, mostly because most will end up living alone when they end up having a stroke, which generally means they'll present to the hospital in a more delayed fashion, when there is no partner or caregiver around to witness symptoms. That means that they're also more likely to live in a long-term healthcare facility after they've had a stroke, and overall have a worse recovery after their stroke. So I'm very happy to see that this, group here is, I see a lot of women here, and we'll talk a little bit about how to prevent stroke in women. Not just women, but we'll talk about in general as well. But specific to women, migraine is a very common condition among women, and unfortunately, we don't know the exact connection between migraine and stroke, but we know that women who have a history of migraine, especially migraine with aura, are more likely to have strokes. And then, of course, smoking is another risk factor for stroke. So, of course, if you have a history of smoking or you currently smoke, we strongly advise you to stop that as quickly as possible. Pregnancy, women who are pregnant should also be cognizant of their blood pressure, as that tends to rise during pregnancy. And during the peri-pregnancy period as well, afterwards, we need to keep a close eye on blood pressure. With regards to age, women over the age of 75 should be screened for this condition called atrial fibrillation, which I'm sure we'll go over in a little bit. But if you're not sure about what that means, or if you need to be screened, then we highly recommend that you discuss this with your primary care doctor. Birth control, that's another thing similar to pregnancy, in that women, before they start any sort of birth control regimen, should be screened for high blood pressure. And again, any woman or men with concerns about high blood pressure and stroke should consult a doctor before making changes in terms of their medications. So we'll talk now a bit about the treatment of acute stroke. And while this picture may look a little bit aggressive, this is actually quite accurate in terms of what it looks like when patients come into the emergency room with stroke. There's oftentimes a large team of people who are helping to take care of the patient as quickly as possible. And that is because, as mentioned, time is brain. That's like one of the biggest sayings we have in terms of stroke care and stroke neurology. Time lost is brain lost. And we consider stroke to be a golden hour emergency, which means that treating a stroke as quickly as possible is the best way to ensure a good outcome or a better outcome from stroke. And we know that actually, if someone receives treatment for their stroke within the first hour after their symptoms have started, that's the best chance they'll have at regaining their functionality back and having the least number of disability related to their stroke. And that's because each minute that passes after someone's had a stroke, about 2 million brain cells or neurons die, which is a tremendous number of brain cells to lose. So every minute counts, and that's the reason why we act so quickly and so aggressively up front as possible. So there's two different classes of treatments for acute stroke. The first I'll be talking about here is what we call a clot-busting medication. There's two different types of clot-busting medications. One is called the abbreviation TPA, or tissue plasminogen activator. The other is called tenecteplase, or TNK. This is a much newer medication that is available for all strokes at Long Beach Memorial. But the most important thing to really understand about these medications, you don't need to understand how they work necessarily, but it is crucial to establish the last known well time, that being the time that someone was last seen well without having symptoms, and the most accurate time that we can actually gather from people is a time in which we witness symptoms to start. And that's because giving these medications is actually really completely dependent on the time in which their symptoms started, as treatment beyond that time window can actually lead to more detrimental effects to someone related to mostly hemorrhagic complications or bleeding complications from their stroke. So treatment is very time sensitive, and if you or your loved one has a stroke, the most important piece of information you can give paramedics and the doctors is what time you last saw them looking well. Going into what exactly is TPA, or this clot-busting medication, it's actually an enzyme or a protein that helps, that is involved in the breakdown of blood clots themselves. It is a medication that is delivered through an IV, and it's really only given within the first 4.5 hours of when symptoms started in a patient. So this is the critical reason why we care so much about the time in which symptoms started, or the last time we saw someone well, is sometimes we can't always be certain when symptoms started and someone is found with symptoms later on. Excuse me one moment, I am actually on call and just want to make sure that I'm not getting called about a stroke. So this is actually I find a really helpful diagram depicting the benefit of these medications, TPA or tenecteplase. This is specific to TPA, as you know, this was written up in 2009, actually at UCLA. This is demonstrating, 100 patients here, and in the green, the dark green, we have about 13 out of every 100 that end up having a normal or near normal recovery after receiving TPA for acute stroke. And an additional 19 people out of every 100 will end up having some benefit from the medication. They may not be completely back to normal, but they have some benefit compared to when they first came in. So that's about a 30% chance of improvement from when they come into the hospital after receiving TPA. Of note, about 3 out of every 100 will have either a worse or potentially fatal outcome from TPA. So as mentioned, these medications are not benign and they can have some consequences, but overall very, very safe and potentially beneficial in about 30% of patients. Talking about hemorrhage, which I won't go into a great amount of detail today, but there are a variety of different causes of hemorrhage in the brain, the most common being hypertension or high blood pressure. The longer and longer someone has high blood pressure that particularly goes uncontrolled, the more damage it does to your blood vessels throughout your body, not just within your brain. And as those blood vessels over years and years of time, and potentially also smoking, can lead to additional injury to the blood vessels. This sort of unfortunate outcome, likely will occur if we let it go uncontrolled for long enough. There are a variety of other types of etiologies for hemorrhage. The second most common probably being trauma, obviously trauma to the head. Cerebral aneurysm, as mentioned, leads to a different type of intracerebral hemorrhage. Excessive blood thinning as well. Not necessarily blood thinners in general, but when they're on when you're on too high of a dose, or you have too many additional blood thinners added to your medication list, then that can be a risk for intracerebral hemorrhage. And then there's some other much more rare causes, much less relevant to this population, but arteriovenous malformation is an abnormal tangle of blood vessels that generally is believed to be a congenital cause that happens in young patients. And then there are much more rare causes, but intracerebral hemorrhage is related to, we're learning more and more about other etiologies, including dementia or something called cerebral amyloid angiopathy. probably another, one of the more common causes of intracerebral hemorrhage in our older populations. So now moving on to endovascular treatment for ischemic stroke. I talked about first the medication side of treatment for stroke, and now I want to talk about what I specialize in right now is the endovascular treatment, which is a minimally invasive type of surgery or procedure to actually remove the blood clot from the brain. And I just want to go over these are really illustrative pictures here. This is an x-ray of someone's brain looking face on at their head. And if you can imagine, actually, this is what the blood vessels should normally look like here, with these black lines being the blood vessels within the brain being outlined with contrast dye. And what we specialize in is actually, if you look at this picture here, you can tell compared down here, there's much less blood flow and blood vessels that are illuminating due to these blood clots. And these blood clots are what we're actually able to endovascularly or within endo, the blood vessel, vascular, remove in a minimally invasive way using these devices that I'll show you in more detail here in a second. Thinking and talking about thrombectomy, is just important to be aware that not every stroke will be a candidate or qualify for an endovascular treatment. But it's really reserved for the most severe forms of stroke, the ones in which the blood clot busting medication will not work on these very large refractory occlusions or blood clots, and that oftentimes leads to very, very devastating symptoms. So in that combination of patients where they have a very large blood clot leading to very devastating symptoms, the IV clot busting medication is not enough. And if they get TPA or the tenecteplase, then that's usually followed by something called mechanical thrombectomy, which means removal of a clot, thrombectomy, to restore the blood flow and preserve brain tissue and hopefully reverse stroke symptoms. This is a similar diagram demonstrating, again, the 100-patient group here and the benefit actually of thrombectomy that it has. On the left, you can see that about 20 patients who receive thrombectomy in addition to TPA, for those who are eligible for it, will have a normal or near normal outcome. Another 14 patients will have improvement in their symptoms, and only about 1% of the time will we have a worse outcome. So the numbers actually look even better when we talk about patients who are not eligible for TPA, meaning they presented to the hospital out of the 4.5-hour window that I talked about earlier. So those who do not receive TPA but do receive thrombectomy, about 44% of patients will have some sort of either near normal or improved outcome, and again, only about 1% will have some worse outcome from all of it. So that is importantly compared to those who received no treatment at all. So that's a really nice illustrative way to show the overall benefit that we can provide our stroke patients when they come to the hospital. To go over what exactly does endovascular treatment mean, if anyone's had a cardiac catheterization, it's very similar to that. We basically use two main sources that supply the brain. Most commonly, we'll go through what we call the groin, which is called the femoral artery, and we will do everything in a minimally invasive way. There's no cuts, there's no large openings, there's no scalpel, there's really nothing that will open the brain in an invasive way. We're going through just making a small puncture here and threading catheters and wires up through the aorta, behind the heart. We don't go into the heart, and then up into these blood vessels that supply the neck up there. And then you can see the similar type of route through the radial artery. We can go through these blood vessels and go around and above the heart to get up into the brain. And this actually just shows once we get into the blood vessels in the neck, we can show and get up into the blood vessels that way, into the brain. And this is actually one of the devices that we use. It's called a stent retriever. And it's essentially a stent on a stick. So if anyone is familiar with what a stent is, actually neurology has taken a lot of the terminology and techniques from the cardiology literature and studies that's much older than stroke care, and basically came up with this idea to place a stent, which helps to open blood vessels on a wire or a stick, so to speak. So it's not a stent that remains permanently in the brain, but one that we're actually able to retract and remove after capturing blood clot. And so this is how it actually works. We have a blood clot here in one of the large blood vessels, and this is showing what an angiogram shows, that there's no blood flow beyond this blood clot. We snake a wire through the blood clot, followed by a catheter, which is a plastic floppy tube. And the catheter actually allows us to deliver this stent retriever, which we call a solitaire, up into the blood clot, which is sitting here. And actually, once we remove the catheter, that opens up this stent, encompassing the whole blood clot. And then once we have it deployed, we will retract it into the catheter. Generally, we'll have another larger catheter here that's hooked up to a vacuum aspiration machine to help make sure we capture all small blood clots. And then, as you can see, blood flow is restored. Some live pictures, some real pictures, not animations, of real patients we've had. This is, again, looking at a lateral view of the brain. And this is where the site of the occlusion is. This is the picture of the stent retriever, or the solitaire, that is deployed in this blood vessel here. And this is a picture of that catheter that we will retract the stent retriever into. And once that's completed, then we are able to actually remove things like this. These are the blood clots that are occluding the blood flow. And we're actually able to restore all of the blood flow like this. So, and oftentimes, this does serve to reverse all of the symptoms of the stroke, or the vast majority of the symptoms of stroke. So I guess Angie will now tell us the best way to treat a stroke is to not have one at all. And we'll talk a little bit more about prevention. So thank you, everyone, for your time. And I'll hand it off to Angie.
All right, how's everybody doing? Yeah, so far so good? All right, I'm going to tell you how not to have a stroke. That's my plan anyway. So let's see. There we go. So this is the objectives. When I teach, I'm supposed to have objectives. What happens when you have a stroke, symptoms of a stroke, understand why some people have a stroke and some people don't, and then how do you prevent a stroke? Okay, so I did this a little different this time, and we're going to talk about not a real patient. Well, in the end, he's a real patient. But so we're going to do a little case study. This is our patient, okay? At 10 o'clock in the morning. Why is that important? Dr. Fukuda talked about we have to know when you were last known normal. That time is really important. So if you're coming into the hospital, we need to know. You need to get our phone numbers, you need to call us, you need to ride along. We need to know when the patient, the person having stroke signs, when they were last known normal. Very, very important in our time frame to keep them safe. That's how we make the decisions on what interventions we can do with them. So last known normal is really key. So at 10 a.m., we got a 52-year-old guy here, young. You know, we had a 29-year-old a couple weeks ago, a 35-year-old today. We have lots of young people having strokes. Stroke patients are not all 70, 80-year-old. So 52-year-old gentleman was home with his wife when he suddenly could not speak or move one side of his body, the right side of his body. All right, what would you do if this happened? Well, that's the right answer. Good job. You know what a lot of people do? They go take a nap. Because it's going to go away. It doesn't hurt. There's no pain with a stroke. With an ischemic stroke like this, sometimes people say maybe a dull headache, but there's no pain. So if you have crushing chest pain, do you have any hesitation in calling 911? Absolutely not. But if all of a sudden, you know, this sounds extreme, he can't talk, he can't move the whole side of his body, but some patients may just not be able to move one arm very well. It's numb, feels like it went to sleep. I'm going to go lay down. And when they get up, then they can't speak and they can't move the whole side of their body and they fall out of bed and it's been 8 hours and there's maybe nothing we can do. So don't go take a nap. Okay, take it serious. And it's better if you call 911 because 911 calls us, lets us know you're coming. And you know the big team she was talking about that meets you at the door, we'll all be waiting for you. And so, but if you drive in, then you got to come through our emergency room waiting area and you got to go through triage. But if that ever happens and you do drive in, make sure when you walk in you say, I think I'm having a stroke. Don't mess around. Now, they're trained to spot people with strokes, but don't just tell them, I think I'm having a stroke. And we will whisk you in there just like you were having crushing chest pain. We will take you back because time is of the essence. Time is brain, and we want to save as many of your brain cells as possible. All right, so you call 911, right answer. So, your brain is dying when you're having a stroke. And so it really, really is very important to call 911. And I can't tell you how many times people go back and take a nap and they wait, or especially if it happens in the middle of the night and they don't take it as serious. So what's going on inside your brain? So Dr. Fukuda talked a little bit about this. I just wanted to reiterate a little bit because I want you to remember a few things, and repetition's good. So over here on your left, that would be an ischemic stroke. Let's see if I can. So here you have a clot that blocks an artery in your brain, and everything on the other side of that clot's not getting blood, and blood carries oxygen and glucose, and without oxygen and glucose, those cells will start to die, and it starts right away. So a couple of examples when I say it happens suddenly. One of my patients told me, I was brushing my teeth, and I put the toothbrush down, and when I went to lift my arm to rinse my mouth, my arm wouldn't work. That's how fast it happens. Or I've actually been taking care of a patient and talking to them on the bedside, and all of a sudden I could see their face start to shift, and they all of a sudden have a facial droop, and their shoulder will start to drop because they're getting weak on the right side, and you can just see it happening. Some people are sitting at dinner and they're eating, and all of a sudden they start to say something and something comes out that's not understandable. So signs of stroke happen very suddenly. Depending on where in your brain you have your stroke, so depending on where it is, if it's on the left side of your brain, then you're going to have speech problems because that's where your speech centers are. If it's on the right side of the brain, you're going to have more spatial problems because you're not going to know where your body is. They don't even know that they had a stroke sometimes when they've had right brain strokes because they feel normal. They're neglecting the side of the world, and they feel normal because the brain is very different. One side of the brain is different than the other. The back side helps you with vision. The front side helps you with personality. So depending on where your stroke is, those are what your symptoms are going to look like. So what's a TIA? I've heard TIA, it stands for transient ischemic attack, and I've heard it referred to as a mini stroke, but it really isn't. With a TIA, it means it's your lucky day, and the stroke went away. But it also gives you a hint that says, hey, something's not right. So it's like all of a sudden your right arm goes weak and you can't move it, and then it goes away. As a matter of fact, let's see if my video works here in a second, guys. Because if I click, it won't work, right? You guys have to click on it? Okay, give me just a minute, then let me address this. So a TIA is really almost good luck because it gives you a hint that something's wrong. But if you don't do something about it, if you don't go to your doctor, if you don't follow up sooner than later, then you're at high risk of having a real stroke that's not going to go away. So a TIA, you can see this data, and it's probably outdated, but it's significant. Within 2 days, 10% of everybody that has a TIA may have a stroke. And it just keeps getting longer. So in 90 days, 20% is going to have a stroke. So the longer you wait without knowing why that TIA happened, the more chance you are at having a stroke. So now I have a little video to show you somebody kind of having a TIA.
How pretty was that?
Not bad, but not half as pretty as this.
Well, bring it on. My, if the old folks' home is looking for a ringer, look no further.
I'm in the prime of my life, I'll have you know. And these are your genes too, pal. Let's take a good long look at your future. Huh?
Well, I don't know about my future, but I think I can see my reflection.
Such disrespect.
Come on, free shot. I bet you can't make it from here. What, you afraid of losing our bet? Dad, are you okay? Dad! Look, let's sit down, okay?
It's going away now.
What was that? I mean, 1 second you were fine and the next you're all limp.
I'm not sure. My hand went a little numb and I couldn't seem to get any words out. But I feel fine now.
Well, we're still not playing.
Oh, sure, we gotta finish.
No, Dad, sit down. Something just happened to you. I'm calling for help.
You've just watched someone have a mini stroke, sometimes called a TIA, or transient ischemic attack. A TIA is a serious medical condition that indicates blood flow to the brain has been interrupted, usually because of a temporary blood clot in a person's artery. What are the warning signs of a TIA? Well, as you've just seen, a person may suddenly feel weakness, numbness, or heaviness, even in a small part of the body, like the hand, face, or foot. It may be hard to speak or understand words. Things may look blurry or dim, and a person might feel dizzy or clumsy on their feet. You might also experience a sudden headache that feels like a severe migraine. Symptoms might last a few hours or only a few minutes, but a TIA is a serious medical condition regardless of how long the symptoms last. It's your body's way of warning you that you're at risk of having a stroke. Just like chest pains can warn of an impending heart attack, a TIA can warn of an impending brain attack, which is why we also want you to think of TIA as take immediate action. If you or someone you know experiences any of these symptoms, call 911 or get to the hospital immediately. The minutes you save could also save a life.
All right, so now we're going to talk a little bit more about our patient and about stroke signs and symptoms. So our patient has right arm and leg weakness and numbness. So the whole side of his body is very weak and numb. He has right-sided facial droop, and he's not able to speak clearly. Now, sometimes that speech will come out slurred, and you can kind of understand them. They just sound like they drank too much wine. But sometimes they can't find their words, or they can't understand you, so they just appear very confused. Or they'll say, they say something weird out of context. So it could be just slurred speech, or not able to find your words or understand words, because it's right in that area of your brain that does all that. Okay, so this guy's got problems speaking. So these are your signs of stroke here. I want you to remember BFAST, and I think you probably have BFAST on your paper there. So B stands for balance. So in the back of your brain, you have something called a cerebellum. It's a tiny little brain under your brain, and it controls balance and coordination. And so if you have a stroke in your cerebellum, you will be really off balance, and you'll go to fall down, and you're dizzy, and so you won't have good coordination. So it's a big sign for stroke, and that may be all it is that you have dizziness. But understand, if you stand up and you get a little dizzy, well, that might just be a little orthostatic, your blood pressure dropped a little bit, and so it's very sudden, it's a lot of dizziness, and again, pay attention to it, because this is one of the signs of stroke that are missed a lot, because there's a lot of other things that can cause dizziness. So it's not the easiest one to catch. Then you have your eyes. Again, in the back of your head, right above your cerebellum, is your occipital lobe. That's the part of your brain that interprets what you see. So I can sit here and look out at all of you. If I have a stroke in my occipital lobe, you'll all be gone. But there's nothing wrong with my eyes. My eyes are working great. It's just the part of my brain that says you can see these people and tell them, then I can see people and see everything. Isn't working, those cells aren't working, and so you're blind, and it's called cortical blindness from a stroke. Cortex is your brain, cortical blindness. So anything, and other more frequent things that happen with the eyes is visual field cuts. You won't be able to see, your peripheral vision will go away. Facial droop we talked about with our patient. Your face just kind of drops down here on the side. Some are very pronounced and some are not so pronounced. Arm or leg weakness or numbness can be on either side of your body. There's a rare occasion, if you have a stroke in your brainstem, it might be on both sides of your body, but that is rare. It can be on either side. It can be just your arm. It can be just your leg. It can be both your arm and your leg. It won't be your right arm and your left leg. That's not an ischemic stroke. That's something else. But we'll figure that out when you come in. Just come in if something's off. And then the speech I described. Now, what's the time? It's a medical emergency. And again, it doesn't hurt. So people don't want to call 911. They don't want the ambulance bill. They don't want the neighbors to see an ambulance outside my house. They don't want any of that. So don't drive in, though. You need to call 911. It's better to make a mistake than to be stuck in that stroke state when we might have been able to make a difference. Okay? So what's going on with our patient? So he's picked up by EMS at 10:30. That was pretty quick. EMS let us know they're bringing in a stroke patient. That's us at the hospital. They call me. The stroke team meets him at the door. We evaluate you very quickly, take you straight to CAT scan. Then if the CAT scan comes back and you're not bleeding, we'll give you one of the medications that Dr. Fukuda talked about. We'll give you we skipped from, we did TPA in the past, now we've moved to the new drug T&K. But we have to make sure there's no bleeding in the brain before we give you a medication that makes your blood thinner. So it's very important. Got to get the CAT scan first. So we know that the stroke is caused by a blockage. It's now 10:50, and the treatment options are the IV thrombolytic, like I just mentioned, and possible endovascular. Since this is a really large stroke, it's this whole side of his body, he's going to be a candidate for endovascular therapy. Okay, so that's where our patient is now. And now we're going to say, how do we prevent a stroke? So it really is that 80% of strokes that can be prevented is healthy lifestyle stuff. The other 20% I refer to are those patients that unfortunately draw the short straw. There's something going on inside their brain that wasn't preventable, that we may not be able to fix, but those patients, it was not as easy to prevent those strokes. But 80% is a lot of people. We see 1,000 strokes a year at Long Beach, so if we can save 80% of those patients, that's a lot. But you guys got to do it. We can't. So, healthy lifestyles. This is the long list. The best way to treat a stroke is not to have one. That's what it started with. So, living a healthy lifestyle, eating healthy, low fat, low sugar, high fiber, fish, chicken. Don't smoke. Don't smoke anything. We get patients, the drugs out there can cause strokes as well, so don't smoke anything. Manage your diabetes, exercise, manage blood pressure. We're going to look at all of these real quick. We're going to go through them. Maybe. There we go. So, what can we do? Be aware of your risk. So everybody should know what their numbers are. Okay, I know what my cholesterol is. I'm in good shape. I'm on one blood pressure pill, and my blood pressure is 120/80 as long as I take my pill. I know I'm overweight. I've been working on it since I was like 3. And I am exercising, and I'm doing the best I can. I'm a relatively healthy, overweight person. But I manage my issues. I know what they are, and I do the best I can. And that's what you guys need to do. I don't have AFib. If somebody out there has AFib, which I'll describe in a minute if you don't know what that is, if somebody has AFib, they need to control it, work with their doctor, take their meds, do the right things, and it'll decrease your risk. If you're a diabetic, it's not curable, but if you control your diabetes, you control your blood sugar and keep it down in the 150s or 200s, keep it low, it decreases your risk. So really, really important stuff. So there are certain risk factors that you can't control. And Dr. Fukuda alluded to this a little bit. You can't, well, I guess we can try. There's a lot going on, but you shouldn't be able to change I shouldn't say that either. It's harder to change from a woman to a man to a man to a woman. Anyway, women are higher risk, is what I'm trying to get out with being politically correct. But increased age makes you higher risk. Women are higher risk. Certain races are higher risk, family history. If you have every one of your grandparents died from a stroke or parents died from a stroke, you're at high risk of having a stroke. It just is. You can't do much about it. If you have congenital heart disease, stuff from a kid, can't do much about it. If you've had one stroke, you can still do a little bit about it. You can still fix everything that you can, but it's still, you've had a stroke and you're at higher risk of stroke. And then there's one of the most common is sickle cell. There are other conditions out there that cause stroke. And if we went into everything, this would be like a 3-day course. So you're getting the down and dirty tonight. These are the ones that we just talked about. These are the controllable risk factors. So don't be a couch potato. And I'm going to go through, I have a slide on each of these, so I'm not going to spend much time on this one. Blood pressure. Some people say, well, I'm 75 years old, so if my blood pressure's, 160/90, it should be fine because I'm older. But that's not the way it is. That's not the way it works. You need to control your blood pressure. Normal is less than 120/80, and that's where we want to live. Now, that being said, there might be somebody out there that has some other condition that needs a higher blood pressure. So this isn't an across-the-board thing. This is something you work with your physician, but get your blood pressure under control. Get your cholesterol under control. Know what your cholesterol numbers are, and then try to eat appropriately. You should eat more fish, more good oils, if you will, the healthier oils. And I'm not a nutritionist, that's a different night. But get your cholesterol under control. And diabetes. Diabetes damages the vessels in your body. So if you have diabetes, you have a lot of potential for a lot of different issues. So if you've seen a very brittle diabetic, sometimes they're blind because it's damaged the small vessels in their eyes. Sometimes they have sores on their legs that don't heal. And so that's because those vessels that get down to the sores, you have vascular issues, and the diabetes is making those vessels damaged, and then you have those sores and they don't heal. So all these things, the kidney disease, so that's why you see bad people with bad diabetes that might have lost a leg, they're going to dialysis, they're blind. If you have to try and control those things, and it prevents the stroke. But you can see how diabetes affects your vascular system when you think of all those things. Cardiac disease. Think about your heart. When your heart pumps, what is it doing? It's pushing blood up to your brain. So if there's something wrong with your heart, it puts you at risk for different kinds of stroke. So one of the most common things is AFib, atrial fibrillation. So the top of your heart, you have 2 atria, and you have 2 ventricles underneath. AFib is when the 2 atria are kind of quivering. And so the blood goes in there, but it doesn't pump out because they're not pumping like they're supposed to. They're quivering. And so when blood kind of sits around and doesn't go where it's supposed to, it makes clots. And then those clots bounce around, and then sometimes the AFib turns into a regular normal rhythm and beats nice and good and hard and throws those clots right up to your brain. And those are usually the big clots that we can go in and try and get with the therapy that Dr. Fukuda discussed, the endovascular therapy. But AFib, again, can be controlled. You take your blood thinner, you take your rate control meds, work with your doctor and do what you're supposed to, and you'll control your AFib and can decrease your risk for stroke. There are other things with your heart that can cause stroke risk, not as much as AFib, but really if you have a heart condition, manage it with your doctor and it'll control your risk for stroke. We have a missing kid? So we covered the signs of stroke here. We're just going to whip through these real quick because we've done it already once, but there's balance. Okay, there's a few things. You're not going to remember everything we taught you. This is what I want you to remember. Okay, so be fast. Balance, controlling your balance, or if you're dizzy. Looking at your eyes. You having double vision or visual field cuts. Over here, this is called a homonymous hemianopia. This picture over here to my right with the vision loss on both sides of the eye. That's really common with strokes. The balance is off, person's dizzy, the visual field cut, I'm repeating myself, I apologize. Facial droop. The face, again, droops down, and it just doesn't look right. And, that's what you just need to, I'll walk through the grocery store and I'm like, their smile's crooked. I wonder if they've had a stroke. I'm walking around looking at their face. Arm or leg weakness or numbness, usually on one side or the other. And then their speech is either slurred or they can't find their words, and they just sound off. And then it is a medical emergency. Your brain is dying. It's like having a heart attack where your heart muscle dies, but that hurts. So nobody hesitates. But with your brain, people don't always come to us. And so it's really, really important that it's a medical emergency. You call 911. You say, my stroke started at 10 o'clock, and I know I'm having a stroke, and it started at 10 o'clock, and you call 911 and have them bring you in, and then we'll be waiting for you at the door. So get your medical treatment. We mentioned several times, time is brain. So for every minute the brain is deprived of oxygen, you lose 2 million neurons, 14 billion synapses is what makes the brain talk to the body, 7.5 miles of fiber, or if you say 12 minutes, it's about a pea-sized piece of brain that's dying every minute. So, you go and take a nap for an hour, and that pea-sized piece of brain now turned into a tennis ball. So it's really important stuff. So this is our patient. And this is Dennis in the middle. When he had his stroke, it was a few years ago. We still keep in touch. And his wife called us, just like the story goes. He came in very quickly. He was very, very devastated with his stroke. We did give him the T&K, and he was before T&K, so we gave him TPA, and we took him to the endovascular suite and pulled out that clot, and he was back on his Harley in a couple of months, which made me very nervous, but still, he was doing what he loved, and he was able to do it. And so he's doing fantastic. These two nurses took care of him. I saw Tasia yesterday and told her I would put her face up on the big screen today. So, he remembered his nurses because he couldn't talk. And they were in his face and saying, we're going to take care of you, and you did the right thing. And he afterwards just remembered them so much that we brought them all together and had a little kumbaya session. It was nice. And that's it. We got hands raising already, so. And if you have questions for Dr. Fukuda, we get her up here as well.
Yeah, so you guys, first and foremost, let's give our speakers a round of applause. How many of us are walking away with at least 3 things, new information? All right. Okay, so yes, this is your time for Q&A, and because we have some visitors on virtually, I'm going to ask that you just hold on and wait till I get to you with the microphone, if you could ask on that microphone. And anyone online, you to please submit your questions through the chat box there. But one question did come through. We talked about face droop on the right side. What if it's on the left side?
Then you had your stroke on the other side of your brain.
Fair enough. Okay, I saw hand of... Pardon?
So if you're already on blood thinners, what do they do?
If you're already on blood thinners and you have an ischemic stroke, then we got to figure out what's going on. You have another reason why you're having your stroke. Maybe depending on what blood thinner you're on, you weren't within the range. Do you want to add anything?
Yes. Oftentimes if you go to a hospital and you have a stroke and you get a workup, sometimes there's a cause of stroke that we deem to be cryptogenic, or we don't know the cause of it. Ultimately, most of those patients do end up developing this condition, atrial fibrillation, and if you're on one type of blood thinner, such as aspirin or Plavix or Brilinta, that's actually not the correct treatment for atrial fibrillation. That would actually require a different type of blood thinner. So. Mm-hmm.
Since you say that what they do is they give you a blood thinner, how do you add a blood thinner on top of a blood thinner?
We wouldn't.
That's the question.
Yeah, we wouldn't.
So what would you do?
Hopefully we'd take him to IR. Keep talking, I'll be quiet. I'll
Yes.
let the doctor talk.
These medications that treat atrial fibrillation specifically are not 100% effective, and in cases like Angie was mentioning, where the blood has actually been sitting there for too long, then you can still have a stroke that happens even though you're on the blood thinning medicines. Unfortunately, that is part of medicine, is that none of our treatments are 100% effective, and the best treatment is for you to come to the hospital and figure out what's going on, and if you're on the blood thinner and you're not eligible for tenecteplase, then we will take you for endovascular treatment.
I have a question online, speaking on this topic. What about the Watchman? If you're on a blood thinner and you have the AFib and...
Good question, yeah. So a Watchman, for those who are not familiar, is basically a device that goes in this small chamber in the heart where blood clots tend to occur and blocks it off. And is considered an effective treatment for preventing stroke for those who are unable to be on a blood thinner such as Eliquis or Xarelto. I think the studies in terms of Watchman versus anticoagulation are a little equivocal in terms of which one is more effective. I do think that it is a good option, and if your doctor recommends it to you, because you have a reason that you can't be on a blood thinner, then I would talk with the interventional cardiologist about the procedure in more detail.
Hi, I have 2 really quick questions. First, when you talk about the time frame when someone calls it in to when you actually work on the person or get them stabilized, how many minutes would you say that is?
Usually, so you mean when they call in from home?
Right.
To getting treatment in the hospital? It can vary a lot, is the unfortunate answer. But I've seen, particularly around Long Beach, very, very quick, less than 1 hour, we can get a patient from their home at least into the emergency room with a CT scan and hopefully get them some medication if they're, if they don't have a bleed or any other reason they can't have the medication. But if you live in a more rural area where it takes longer for paramedics to get to you, and you're further away from what we call a primary or a comprehensive stroke center, then it can take well over an hour.
Yeah. The second question that I had to do with the, you mentioned if you have a relative, like your mother had a stroke, why is it you're at a greater risk? Let's say your lifestyle is different than your mother and they had a stroke, why are you at a higher risk?
Great question. There's still, I think, a good amount of strokes that are related to some genetic underlying cause that we don't quite understand. I would say if you have a parent who had a stroke and your lifestyles were very different, your parents smoked, they had high blood pressure, they had diabetes, all of those things went uncontrolled for many, many years, those are most likely the causes for their stroke. But perhaps you may have a slight genetic predisposition towards having more reactive blood vessels, developing blood clots, but you, for all the other controllable risk factors, such as high blood pressure, diabetes, smoking, high cholesterol, are doing a good job of controlling those things. We know absolutely your risk of stroke is much, much lower, and it will not guarantee you that you have a stroke compared to potentially your parents.
Thank you. Ma'am?
Yeah, when you call an ambulance, it's known that they don't take you where you want to go. They take you to the nearest hospital. So how does that work out? I know that you guys are, for your medical services, how about any other hospital being able to take care of this problem?
Great question. So, and that's really the job of, part of your job when you're at home and you're calling 911 is to be very plain and clear about if you think you're having a stroke, to telling the dispatcher, whoever is on 911, I think I'm having a stroke, or I see stroke-like symptoms. Don't be, as Angie said, shy about it. You have to be your own advocate and say that. And once those words stroke come up, then the 911 dispatcher will actually potentially, call a different team, and or the mobile stroke unit could potentially come to you. But there are different levels of hospitals that are equipped to do things, and the treatment that I was describing, the endovascular thrombectomy, not every hospital can offer that sort of treatment. So if we're seeing a patient who has severe enough stroke symptoms, they will actually get triaged to a comprehensive stroke center in preference to a hospital that doesn't have that level of care.
Okay. We've got someone online says recently they've had very cold feet at night. Is this related to circulation to the heart? And he acknowledges that he had a heart attack 3 years ago.
It is possible. It's a little challenging to say without seeing you in person, but I would recommend you talking with your doctor about that. Cold feet in and of itself doesn't 100% mean that it's related to your heart, but it is certainly possible.
Okay, sir.
I have a question about the Watchman. I was scheduled to get one, and they said I was too healthy. And the reason I don't like taking the blood thinners is because all I got to do is look at a sharp object and I bleed. And I'm just wondering, is it really safe, the Watchman thing? Is it something I should... I'm going to see my cardiologist at the end of this month, so I need to know if I should push on it. They said you have to have 3 points. I only had one because I'm taking Xarelto. And it's, is it worth...
So I would not recommend a Watchman as an option for someone who is on blood thinners and tolerating it well. A Watchman is an invasive procedure and does, put you at risk for actually developing a stroke. So it's, in that immediate stroke surgical period, there is risk related to that. So for those currently, as we know by the data currently available, A Watchman is not more effective than a blood thinner. At best, it is around the same efficacy with the additional risk on top of a procedure. And in terms of getting the procedure done itself, I would talk with your cardiologist, but the current recommendation is for those where there's a contraindication to anticoagulation, so meaning people who are not eligible for anticoagulation.
Good. Yes, please.
How problematic is it if you also have a brain tumor?
Sorry, repeat that one more time?
How problematic if you have stroke symptoms and you also have a brain tumor?
Good question. There's actually a variety of types of brain tumors. The most common brain tumor is actually something called the meningioma, which is a benign form of a brain tumor. And depending on the neurologist that you speak with, that meningioma is not necessarily a reason why you can't get a clot-busting medicine. But on the very long list of reasons why you cannot get a clot-busting medicine, aka the tenecteplase or TPA, brain tumor is one of them. So, without knowing about specific types of tumor, it is considered a contraindication.
Well, what if you're prone to blood clots and you're on a blood thinner, Xarelto to be specific?
So similar to the other question, unfortunately, being on a blood thinner will be a contraindication to a clot-busting medicine. But if you're having a severe enough stroke, the thrombectomy option is still on the table and potentially one. And one other important note that I didn't actually talk about earlier was in terms of the time window or time frame for thrombectomy. We talked about the 4.5-hour window for TPA. 24 hours is really the time window that we still consider someone a candidate or eligible for thrombectomy. So that doesn't mean, though, that you can wait up until the 23rd hour for you to come into the hospital. But there are cases, of course, where people live alone and they don't have access to someone who can call 911 for them, and they present in a much more delayed fashion. So thrombectomy is a potential option for a lot of people who have other reasons why they can't get a clot-busting medicine.
Sir, you've had your hand up.
Yes, you didn't talk about statins.
So statins are basically for every stroke patient that comes in and has a confirmed stroke or a TIA, that is one of the mainstays of our treatment, is to make sure someone gets some sort of medication to try and prevent their stroke with antithrombotics like aspirin, Plavix, Xarelto, Eliquis. And part of your workup into the hospital is checking your cholesterol level, and if your cholesterol is high, and the number that we care most about is your LDL, or your low-density lipoprotein. If that's over 100, then if you're not already on a statin, we will prescribe that for you or increase the dose of your statin.
Hold on just a second, sir. What about, you mentioned aspirin. Who should take a 81 milligram baby aspirin?
So I think in more recent times, there's been a little bit more controversy over taking aspirin on a daily basis when you don't have a reason to, such as heart disease or some either history of stroke. Some of the cardiac literature more recently has shown questionable benefit of just taking aspirin prophylactically or preventatively without a clear reason. But if you've had a stroke or a cardiac history, aspirin 81 milligrams is one of the mainstays of prevention.
Just going back to statins, the question I have is, my insurance company contacted me to say, hey, you need to take statins to prevent a stroke. Well, I don't have any, in my genes, none of my family had any kind of cardiovascular problems. So I'm just wondering, why are they pushing this drug? For what reason?
My guess is because your cholesterol was high or your LDL was high, but otherwise, Without knowing your other medical history, I'm not sure.
I told him not, it wasn't high, so.
Okay, we got a question right here.
I was just wondering, what are some of the factors that make women more vulnerable to stroke?
So I think I talked a bit about them, if I can maybe go back here. Remember when I was talking about migraine? Migraine is some sort of vasoconstrictive activity that's going on within the brain, and that is one of the risk factors for women, and migraine being more common in women. Birth control or hormonal replacement therapy is another known risk factor for specifically in women when you're on some sort of estrogen replacement, that estrogen can increase your risk of clotting. Well, the main, difference between men and women is estrogen. So estrogen is really a major cause of migraine, obviously involved in pregnancy, obviously involved in birth control. That unfortunately is something we can't control. That's what makes us women. So it really comes down to estrogen.
Okay, thank you. We had a question here.
Yes. Hi. You mentioned earlier in the presentation that it looks like a lot of younger people are being more...
having more strokes.
Yes. And why? I'm just curious.
Why that is?
Yeah.
Very good question. And I think this is, a particular area of interest amongst a lot of people coming into the field. So I think in general, for people who are having strokes, when you're younger, the more common cause of stroke is a hemorrhagic stroke or a bleeding type of stroke. And we just are seeing more and more these days, more effects from obesity, high blood pressure, diabetes. It's just occurring more at a younger age now. And those are, having uncontrolled high blood pressure we're seeing that in even teenagers. Now that's, 20, 25 years worth of damage that's been going on to the blood vessels, and something's got to give at some point, and generally it's a brain bleed that will occur. Stress is interesting. Yes, it can increase risk of high blood pressure. Stress in and of itself doesn't necessarily mean you're more likely to have a stroke, but if you have stress and high blood pressure and your blood pressure is not well controlled, then it certainly can increase your risk for stroke.
What about someone asked B3 and it causes greater risk of heart attack or stroke? Is it true?
I have not personally heard that.
Thank you. And then, can a person have a full life after they've had a stroke, or is it shortened? Maybe they have a stroke, they do the steps that you recommended for healthy lifestyle. Will their life, though, be shortened at all?
I think after someone's had a stroke, and of course, assuming they've had a good recovery from their stroke, I think they absolutely can still have a full life. Angie showed us an excellent example of how that works. It's a combination of many efforts that really allows someone to recover and have a full life and, not have disability related to their stroke. It's related to finding what caused the stroke is probably the number one thing we can do to ensure that someone has a good outcome and recovery from their stroke. If you unfortunately fall into this, what we call cryptogenic or unknown cause for your stroke, then you are unfortunately more likely to have a second stroke because we didn't really understand what caused it in the first place.
But I think you ended it very well. Like, if we do have one, for the most part, our lives will not be shortened. Thank you so much, both of you, for fantastic information. I recognize some people still have some questions. Feel free to come and talk with our speakers, but it's almost 7. So we want to thank you. Please do your evaluation, because I'll tell you what, the topic tonight came from attendees' feedback that this was of real value. So please fill it out and or use the QR code. Thank you.